Opioid analgesics do come up with some key considerations for prescribing, mostly because they have this high risk for abuse and have an abuse potential. Most opioids are controlled 2 substances. So let's start out with some guiding principles. Number 1, you always check the PMP prior to prescribing opioids. 2, for acute pain, as we mentioned before, 3 to 5 days supplies. You can extend to 7 days if it takes longer to improve. 3, always pick immediate release. You do want to use it for acute pain, and then you try to use it at least initially for chronic pain. Make sure patients safely dispose of leftover medications, and then we do also need to think about when to prescribe naloxone therapy. As you guys may remember, naloxone is the agent that is used to reverse opioids. It is a pure opioid antagonist, or mu-opioid receptor antagonist. And we will talk about those specific guidances that are given by law. Now, another thing we want to think about is routes of delivery. The number 1 rule in all pharmacy is if you can use the oral route, use the oral route. For opioids, we do try to use immediate release first, whether it be for acute pain or chronic pain, using immediate release only for acute pain. If we do need to use extended release, especially in chronic pain conditions, we can, but it's really for chronic pain only. And there are abuse deterrent ones. These are formulations that may be combined with naloxone or naloxone. But these are agents that use these abuse deterrent abilities to try to decrease your use of, like, let me just explain this. Oxycodone with naloxone is a drug that you can give. The naloxone part is so that you cannot crush it up and try to inject it, because if you do try to inject naloxone, it will cause reversal. So there are abuse deterrent formulations. There's also formulations that have special powders or special formulations on the sides of them that will make it harder for it to be crushed. Routes of delivery. You have IV pushes, continuous infusions, and patient-controlled analgesia in the intravenous route. You can also have what's called a PCEA, so it's patient-controlled epidural analgesia. But primarily this is used through the IV route. This is an example of a PCA, or a patient-controlled analgesia. What a PCA is you have the syringe here, and then what the patient can do is if they press this button, it will give them a little dose of opioid. This is called the demand dose. IV pushes usually get ordered as like Q3 hours PRN. Continuous infusions are primarily used for the ICU and for sedation. And you guys might learn about that a little bit more if you take the ICU elective. The epidural and intrathecal routes do inject it right into the spine. They do help with pain management as well. So some key considerations as we look at the opioid laws. So looking at that, you do have things like day supply limits. This is via the law. Now, we do ideally want to use just 3 to 5 days for acute pain, but per the law, you should not have more than 7 days. If it's post-surgical, you should have no more than 14 days. If you have to go longer than this, you do need to have a documented reason in the medical record. Similarly, with prescription strength limits, you need to have less. If you have greater than 50 morphine milliequivalents, you have to document reasons in the medical record. And then similarly, for greater than 120, you have to document a reasonable justification or refer a consult a pain specialist. So make sure that you know these numbers. So 50 morphine milliequivalents, you do need to have documentation in the medical record. Once you get to a greater than 120, you do need to have a refer a consultation to a pain specialist. You do want to co-prescribe naloxone based on patient-specific risk factors, including, once again, this 120 morphine milliequivalents per day. If a patient has prior overdose, a history of substance abuse, or is using concomitant benzodiazepines. You do not want to co-prescribe with certain agents such as benzos, sedative hypnotics like Ambien, cardisoprol, although other skeletal muscle relaxers are allowed, so keep that in mind, and tramadol. Tramadol is actually also an opioid, which is kind of funny, but the idea here is that it's a partial opioid or has other agonist effects or mu opioid receptor agonist. Now, it can be allowed, but you do have to have documentation and a tapering plan.